just gonna start some opening comments here and then introduce the panelists. But good morning, everyone. As mentioned, I'm John Pullman, the Director of Innovation with the One Utah Health Collaborative. No one gets that order right, so I wish we had named it something different. I just wanted to start with just a couple. I just want to jump to that first slide. A lot of sponsors, very impressive. All right, I think our slide's going to come up in a minute. Today I'm privileged to facilitate a conversation with three of the most influential people in the healthcare system in Utah. I'm really grateful. Before I give their introductions, I just want to give a little context for why we're having this conversation. We all know that Utah is home to some of the best healthcare in the entire world. We have top-notch facilities, we have fantastic clinicians, we have a healthy lifestyle for the most part, and that keeps our costs generally low. But we also know we have challenges with it. We have a primary care shortage, our behavioral health outcomes aren't great, our costs are growing a little faster than you see in other parts of the country. And so in that sense, we have work to do. And thinking about why this matters, I just want to read a quote from Derek Miller. He's the CEO of the Salt Lake Chamber and had senior roles in Governor Huntsman and Governor Herbert's staffs. He said, "Utah has one of the strongest economies in the nation. That does not happen by accident. It takes looking forward to do everything we can to remove obstacles out of our way. And I can't think of a greater obstacle than we have in our pathway to prosperity than healthcare." So to me, this quote is both sobering and encouraging. It's sobering because the threat is real, but it's quite encouraging because Utah has a track record of dealing with things before they get worse. Last year, the board of the One Utah Health Collaborative, and these are the organizations, it's made of the CEOs of the health systems, the payers, the large medical groups. They oversaw a statewide listening tour from patients, clinicians, and employers asking, what are your priorities for our healthcare system, and reflecting on it. The feedback was unequivocal. People want a healthcare system that is affordable, high quality, and trusted. Trusted was an interesting one that we'll talk a little bit more today. So these CEOs got in a room and talked about what does an ideal healthcare system look like that will deliver on those three values. And this is one of our sessions. Rob, I like seeing you there. You look like you're having a good time. I think you had a good time there. That process what came out of that is what we call the Utah model of care. The Utah model of care describes what this ideal state is. It's 7 attributes: accessible, efficient, person-centered, prevention-oriented, rewarding outcomes, optimizing workforce, and transparent. And if we can have a healthcare system built around this, which is going to take time, and that's why we set a goal of 15 years, this is something which will yield those priorities. We are doing some things together with these executives and teams and their companies. We're measuring spending and quality, so we're really knowing our progress and how we're doing at a very granular level. We're identifying areas of action through a cost driver analysis using the all-payer claims database, and we're coordinating among us some key initiatives around removing barriers to cancer screenings, modernizing digital health interoperability, and a program on diabetes prevention. But each organization also has to act independently, and that's what our conversation is today. We're fortunate to have these three leaders who are at the forefront of their efforts to share some things that they are doing and what is working and where the challenges remain. So I'm joined by Evan Ray, who's the president of HCA Healthcare Mountain Division. Mountain Star is the name that we often see around here. Rob Hitchcock, who's the CEO of Select Health, and Gina Hawley, who's the chief operations officer of the University of Utah Health. Join me in welcoming them. Okay, does this mic work too? Thank you all. This is fun. Rob, I think there's a blind side with some of your staff there, but they know what you look like, so it shouldn't be too much of a problem. We can move the podium if you want. Opening questions. So some of these questions I'm going to ask to all three of you, and a couple probably just direct to a couple or one or two of you. But the first one, and we can start going down the line, but we'll mix this up. So Evan, for you, what concrete steps is your organization taking to build a healthcare system that is more affordable, high quality, and trusted? And can you share a specific example or two that's making an impact?
Yeah, when I think about just cost in the system, two things come to mind for us. We were early adopters of the ASC business. We'll have close to 20 ASCs across the Mountain Division here by the end of the year, and that has just embedded value from a cost perspective to the broader health system. And then Mountain Star Care Partners, I see Kelly Frazier in the room. She's our leader of that organization. We've got roughly 900 doctors across our 3 states, with the density of those being in Utah, where we come together with primary care providers and payers to create value and drive behavior and practice patterns through contractual quality incentives.
Great, thanks, Ian. And I just want to underscore, I was not aware of some of the value-based care work that HCA is doing until I met with Kelly and learned about it. I think that's kind of a secret, great thing that's going on in Utah and some of the, with your clinically integrated network. So thanks for leading that, and we should tell more people about that. Gina, do you want to talk about what's going on at the U of U Health?
Yeah, there are so many great examples that I was thinking about when I was looking at the Utah model of care, and I think I'm just going to talk a little bit about trust and accessibility and person-centered care. One is that we are lucky at U Health that we are opening up a couple of different facilities. We have our new Ken and Carolyn Garner Crisis Care Center opening up Friday. Super excited. I hope to see some of you there tomorrow. We also have, with our Huntsman Cancer Institute, opening up a new facility in Vineyard, and West Valley. We're opening up a new hospital and health center in West Valley. Talking about West Valley a bit, we know there's disparities in care. Just going 20, 25 minutes to West Valley, there's a 10-year life difference in life expectancy. 10 years difference, just by 20, 25 minutes out in West Valley. Residents of West Valley drive 12 million miles on average to get their care back and forth between some of our U of U health sites. And so we know we have an opportunity, and that's where West Valley, just speaking for a couple of moments there, will be really neat in terms of accessibility, right? Bringing care back to those patients in their communities. That project actually has been one of the most fulfilling I've worked on. The community partnership has been so amazing. We have worked tirelessly with the community, not for us to tell them what that community needs, but for them to tell us what they need. We've had 130 forums with 300 community leaders. We have just really worked tirelessly to really understand their needs. And I think when you talk about community and accessibility and trust, it's really important. Switching also to a little bit about telemedicine and accessibility. We have a very robust telemedicine program. We have 23 affiliates at U Health. We have 53 telemedicine sites. Locally in the state, 60% of our telemedicine visits are in rural areas. And just to note the accessibility there, we want to keep patients in their communities as best possible. But there's also a trust factor that really works quite well, is that if you're, for example, a stroke patient, and you're getting care through telemedicine at U of U Health, then you actually have to come in for care. A lot of times we have the same providers that they got the care and they were on the video with that saw them. And a lot of times our patients or loved ones are shocked because it's the same team. And so I think that trust is really important to continue on. We want to keep them in their communities, but if we can't, at least they've worked with the team members and those providers just really seamlessly.
Rob?
Yep, thank you. First of all, I have to say thank you for not seating me in between the two hospital systems. So tender mercy. So what we're working on at Select Health, we have 2 strategic priorities. One is simplification. And what we're focused on, we spend about $15 million a year just investing in technology and making it easier for hospital systems like HCA or the University of Utah or physicians to access information. So mostly physicians are calling in asking, is the member eligible? What's the status of my claim? And so we put a lot of effort into systems that they don't have to do that. They can actually just go online or through an app and they can get that information really quick. We invest in that heavily. And making it easy for our members to access care and access the services they need. The second one is value-based care. We spend an enormous amount of time thinking about trying to do value-based care. And the challenge with value-based care is really kind of a fundamental issue. If you think about the United States, we as a country decided in the early 1900s that healthcare was a market commodity. Healthcare in the United States is not a right. It is a privilege, right or wrong. And so if you have money, you can access care. If you don't have money, it's more difficult to access care. That's the foundational model that we operate on in the United States. So with that, and the fact that we've practiced medicine that way for the last, 120 years, that is the culture, if you can describe it as that is the culture of medicine in America. And so how do you change culture? At the end of the day, value-based care is really about emptying the hospital, fundamentally. And that's hard to do. And so what we're trying to figure out, at least at Select Health, is how do I encourage that while at the same time protecting the revenue stream of the hospital, right? And so to me, value-based care is all about aligning those financial incentives so that the hospitals aren't harmed in this journey, and that the physicians aren't harmed, and more importantly, that the patients and members aren't harmed, that we actually improve access to care. And that's very, very hard work. I will say that if you're a clinical organization that's highly interested in value-based care, it's very difficult to find a payer who's willing to do that. And if you're a payer, it's very hard, and you're interested in doing that, it's very hard to find a clinical organization that's willing to do that. And so that's kind of the journey we're on, those two things. But we think fundamentally at Select Health that this journey on value-based care is kind of the solution long-term to making healthcare more affordable, more accessible, and producing higher quality.
Rob, can I ask you a follow-up on the value-based care? What prevents you from finding partners who are willing to do it too? It takes two to tango more oftentimes. What are the barriers that you see with hospitals or clinics or anyone in the spectrum?
Right. So I think from a payer perspective, payers like the margin that they have. And so as a payer, if you're making a margin and you go into a value-based contract with a hospital system or a physician, then what you're fundamentally doing is you're giving up a portion of your margin, right? And then from a clinical side, I think there's two things. One is the culture of medicine in America is if I bill more, I make more, and I can send my kids to college. At the same time, I want to do the right thing for the patient, right? And so that's hard to change that mindset. It's hard to change that mindset. And then if you're so like we're working with a hospital that we're going to capitate payment to them. Well, you think, well, that sounds great, right? And from a payer perspective, I like that because what I'm doing is I'm protecting their revenue stream. So I'm saying, okay, I'm going to pay you this amount. And so now, if you have less average daily census in your hospital and you're moving it more to the ASC, which I love that strategy at HCA, then you're going to make a higher margin. You're going to make a higher margin by doing good. But the challenge is I think that most hospital administrators that I know or CEOs have been raised in this culture of heads and beds. And so even if I lock in their revenue, how do you change that mindset to say, okay, now I can really move to the outpatient side and I can really partner with the doctors and I don't mean to pick on the hospitals. It's the same fundamental issue with physicians. How do you get them to bill less, to spend more time with the patients? And I think it all starts with protecting their revenue stream and then working together as a partner.
Great, thanks, Rob. You said your little icebreaker joke was that you didn't want to sit between the two hostile organizations. Let's turn to those and see how Evan and Gina feel about that. I think what's interesting about this collaborative is the idea of putting competitors at the table, across the table from each other. And we started talking about a spending growth target. We talked about coming to agreement on what we want our healthcare system to be like. Gina, maybe we can start with you and then go to Evan. As you think about competitors, working with competitors, what makes sense as far as having a shared goal, but does competition ever get in the way? When is it helpful and when is it challenging?
Well, I think it's traditionally been challenging, right? Like you think about just the usual structures of us being competitors, and we're all in it to what you had said, we're all in it just because we're trying to do right by organizations and for the communities, but we're in sort of a silo mindset, right? I heard a great quote that in healthcare, it's easier to silo. It's really hard to de-silo. And I really find that true. So, but I would have to say that I think I've been lucky in my career and paths in different organizations that I've worked with and states that we have actually really partnered to the points that are being made that we need to sort of move ahead together, because honestly, when you think about scarce resources, quality outcomes, things of that nature, to do it in a silo factor doesn't make sense. And that's not just across the state, but it's even within departments in your own health system. And so from a global point of view, I 100% agree. I think in an ideal world, you don't want patients in the hospital. From a population health model, you want them getting care closest to home, in home if able, and do as best possible. Our system traditionally has not supported that. So we have to really be innovative in the way we think forward.
Well, I'm preferential to patients in the hospital.
Okay. Say it like you feel.
Hospital business, so I get the point. But I think what you guys are putting together with One Utah Collaborative is really important, because there are finite resources, and if we go about it in Utah and the 4 systems that are the largest systems and continue to compete, I don't know that that's the best for the patients in the community. As far as examples of working with the competition, there's not that many, and that's why it's hard. I think all of the systems do a better job of partnering with the large physician practices and the multi-specialty physicians in the community, maybe versus each other, and that's not unique really to Utah. So a couple of thoughts.
Yeah, thanks. Evan, can I follow up, kind of going back to your clinically integrated network, and I know we didn't talk about this before, but I'm interested. So you have chosen to partner with a lot of smaller group physicians. You just mentioned a large group of physicians, and we have the Tanners, Revere's, and Ogden, and Granger, and Rob contracts probably with all of them, and they do great work. You think a lot about these smaller docs. Why have you taken that approach, and what are the things what are you trying to help them with, and what are you trying to get back from that?
Well, it's a contracting strategy, number one. It helps them with some of our payers in the market. It's an alignment strategy, obviously, as well. And then finally, it's a quality strategy. I mean, when we think about the world, sort of the elements of the business are earnings, quality, and experience. And if you can drive value for patients in each of those 3 work streams, it's good for the organization.
Great, thank you. So all 3 of you have not spent the bulk of your careers in Utah, and glad you made it here, though. Or made it back. Rob, did you start here on the left and then came back? I thought you overheard you. No, okay, you're a convert. So you've seen other. That means something different in Utah, but enough didn't
Laugh, that was funny.
Yeah, that's what everyone said when you were moving here. But curious, as you've seen healthcare in other states, and Jeannie, we talked a little about Maryland, so maybe we can talk to you, like, as you've seen healthcare in other states, what is different about the healthcare system in Utah than you see in other states, and where do you feel you're optimistic that we can make change, and where might we have some challenges in that?
Yeah, actually, it's a good segue from the last question. I've been honored to work at great systems. I love being in Utah. The people here are amazing. Been here about 2 years. Prior to, I was in Oregon for 8 years, and then Maryland for 9. So we'll talk about Maryland for a minute, and then we'll go to Oregon. And it's really under the whole thing of collaboration, which is why I answered a little bit that question prior the way I did. So Maryland, when I was there, I worked at Johns Hopkins, was an all-payer state. It was the only state capitated, so the states set rates. And so as a healthcare administrator, it was sort of fascinating being in Maryland. You never made too much money, but you never lost too much money either. But what that meant is actually you worked really closely with the other hospitals. So, right, there was, Baltimore and Maryland is a very small state, but you worked very collaboratively on outcomes, curbing costs, and it was great as a citizen of Maryland because they were able to curb costs. They had an exemption from CMS because they were able to showcase at that time they were able to keep costs, the growth of costs lower than the national rate. Is that it actually helped serve uncompensated care in Maryland. There's no safety net hospitals in Maryland. We were all expected to take our fair share, and we had access to each other's data, volumes, outcome data, and so forth. So when I worked at Hopkins, I was able to see the other health systems data because of the HSCRC. I will asterisk that program is changing. They just went to the AHEAD model, which is a collaboration with Vermont and Connecticut. Just noting a lot of changes going on. We'll see how that goes. The other example I'll say is in Oregon, being there during the pandemic, is that OHSU, Oregon Health and Science University, where I worked, partnered with GE on a bed board. And what a bed board is, it's like air traffic control, where you look at your beds across the system as transfers come in, given that it's such a scarce resource, trying to really match where patients should go. Well, during the pandemic, we partnered with all hospitals in Oregon to have a statewide bed board. So as transfers came in, we would all be coordinated on where patients should go, given how busy the hospitals were. This work has continued in Oregon. They have the Oregon Medical Coordinated Care, the OMCC, and the Oregon Behavioral Health Coordinated Care System, where if they're at high capacity, referring providers and hospitals could call in to get coordinated care. So if they're looking to get into OHSU may not have a bed, they could send it there. Why that's really important is that's not like that in other states. I won't name the states, but during the pandemic, I was instant commander during that time at OHSU. I will note, talking to other friends and colleagues, there were other states that were like, nope, this hospital, there's health system going to work on their area, others are going to work on their area. Short-term game, right? Not good long-term outcomes. And that's why I think where we're going for the Utah model of care is really good to work together.
Yeah, thank you. And I think when the collaborative started, it was a little bit the heels on COVID, and I think the way you saw the health systems come together during COVID made everyone a little more optimistic that there are times in which you can sort of look to you can be bigger than your initial self-interest and think ahead. So thank you. I'm really grateful you're bringing those insights here. Rob, from a payer perspective, as you think about what does the landscape look like different here, and what lessons can you bring from where you've been, and where do you have optimism in Utah?
Yeah, it's a great question. I would say the thing that Utah has going for it, which is unique to any place I've lived, and kind of a fun fact or a sad fact, I don't know how you view it, but I have 4 kids and my wife and I, and so all 6 of us were born in a different state. That's how many times we moved. Poor kids. So if any of you are behavioral health specialists out there, we could probably use some therapy. But the thing that Utah has going for it that is unique to any place I've ever lived is you have 2 systems, the University of Utah and Intermountain Health, that are integrated systems. So they own hospitals, doctors, lab, pharmacy, and a health plan. And I have never seen that ever, any place I've ever lived. You might have one here and there, but to have a place where you have 2 of those is really unique. And so what does that allow you to do? You have 2 organizations that fundamentally wake up every day with this dilemma, right? Of how do I fill the hospitals and how do I empty them at the same time, because I own a health plan. And I think that's a good thing. It forces these 2 organizations to figure out how do we deliver value, and how do we lower costs, and how do we serve the communities where we live. And it's a very unique thing.
I want to turn a little bit to trust, and Evan, maybe we can start with you and then go to you, Rob. So when we did this patient survey analysis and looked at what comes, so affordable, high quality, no one's surprised to see those as key priorities. Trust might be something that you were surprised to see, and we were surprised to see it as well. So access is typically the word that you think of that, but access went into the model as far as you want to be able to access care. But as far as an innate priority that people had was trust. And we looked at that data and we felt we had to put it in there because it was important. And we're going to do another patient survey this year to see if we can dig in a little bit more to that. COVID, we know there was a loss of trust in that, but we've seen other data that shows there's a decline in trust to physicians, decline to health plans. We've seen really some tragic events of people. Anyway, there's been hard things and evidence that trust is kind of broken in other places. I'm sure you think about the patient a lot, right? And trust. Evan, how are you thinking about restoring that trust? What do you think is actually helping to erode that, and what are you doing at HCA to help change that?
Well, we've got all the feedback platforms, the Press Ganey, the online tools, and getting direct feedback from patients. But I think, the physician-patient relationship is still among the utmost important. And when you have, world-class outcomes and high-quality outcomes, the physicians bring their patients back to you time and time again. And I think the trust is not just between the provider and the patient, but it's a triangulated trust with the physician community as well. And we've been a top 15 health system for the last number of years, as has Intermountain Healthcare. And I think just the objective outcomes and making sure that our physicians are aware of that and communicating that to their patients builds an embedded trust between those three critical partners, the physicians, the patients, and the hospitals.
Okay, thank you. Rob?
Well, this is fairly personal for me. So, you referred to the tragic event. It was the assassination of United Healthcare executive, and I think the way that the public reacted to that was a justifiable killing. And some of the things that I think that we have taken away, at least me personally, and I think Intermountain, we talk a lot about this, is the fact is people don't trust us. People don't like us. They're angry, really angry. And we, it's a big problem. And so I think one of the things I love about the One Utah initiative is coming together, whether we're competitors or not, and saying, hey, we got a fundamental problem here. Healthcare is too expensive. It's hard to get in to see the doctor. People are making choices on, do I fill my prescriptions or do I go buy groceries? Do I pay my rent or do I pay my health insurance? And it's a real thing. And I think if you were to ask anybody in this room, they would have a very negative experience with the healthcare system. And that's a problem. So we need to fix that. And I would say I don't have the answer. I don't know what the answer is, but it's a big problem.
Thanks, Rob. Gina, I think you were mentioning to me that patient experience now flows up to you as you think about trust and restoring that trust with patients. What kind of tactics do you take or would you like to take in the system?
Yeah, I think about restoring trust, and it's how do you get that seamless care and that listening component. I was just talking with our patient experience team about the term medical gaslighting. So that is a term where it is felt that patients are not being listened to, that they're talking over the patient's concerns, right? And actually, gaslighting, interesting fact, it was the Webster Dictionary word of the year for 2022. Interesting enough, when we were looking at this, and when you look at our patient experience comments, there's a lot of discussion on gaslighting. There are a lot of comments. I came in, my teenager, this is exact quotes, my teenager had a headache, and the provider said that she was just moody. I spent $10,000 because I had this extreme back care, and the provider wouldn't listen to me, right? And so those are really tough things to hear. And so, but I think how you resolve that is really like why that's something really interesting to me, is that we're working with our teams to really enlighten the providers and the teams about, hey, how do you support your team, your patients and their loved ones in a different way? I will note that our teams are at a different crux, right? We are luckier because we're in Utah, we have a better economy, but it's also harder to sometimes fill those gaps because we have such a good economy. And part of it too is that we're at a crux because we have a lot of our more tenured providers and team members that are retiring. And so you have a lot more junior providers and teams. And so how do you educate them to really listen, to really be collaborative, and note what the different changes are going on in our society and things that we have to provide care in a different way, I think is really important.
Thank you. I think we're going to have a few minutes for Q&A, so let me ask another question to the group, and but be thinking if you have a question for them as well. Raise your hand if you've spent part of your career trying to make healthcare better. Right. All right. Keep. You can take it down if it's been easy. All right. What's up? Healthcare is hard. There's a podcast I listen to, and that's what it's called. Healthcare is hard. It is hard. It's full of trade-offs and challenges, and I think everyone who's in it wants to make it better because they see the challenges, but gets discouraged along the way. So, Gina, I want to come back to you first. You have a good heart. All three of you have good hearts. You've been trying as you've tried, and what kind of keeps you going to try again when you keep running into walls, which undoubtedly we all are?
Yeah, I think there are two things. I mean, there are several things, right? Our patients and communities are really important. Our teams, as I mentioned, really important, just giving out the burnout and wellness of what they go through. The frontline teams are the most amazing people, and it's just a hard time of how we continue, especially with the aging population and the needs. I will note personally, my family drives me quite a bit. John, you and I were talking. We both have kids a similar age, and I am part of what you would term the sandwich generation. I have young kids at home, 7 and 10. They're amazing. John and I were talking about how to manage them. I'm not going to speak for John. I'm not managing them effectively at all.
We're having peer therapy, actually.
Yeah, that's exactly.
Both had
Speaking of therapy session. But I also have older parents that are going through healthcare issues, right? Memory, dementia, the whole thing. And so I think about how hard it is for me to access care sometimes and navigate. If it's hard for me, it's definitely hard for many, many other people. And so that's what personally drives me, is trying to make that better.
Yeah, thanks. Rob, you have a heart too. Do you want to go and then we come to
He's
Evan?
a payer.
Yeah.
I have no heart.
Hey-o.
No, I actually graduated from the University of Utah. I think that's why you thought, I was from here. I born and raised, but I graduated in economics and sociology, and so I describe it to people all the time. I have a hard head and a soft heart. So I think at Select Health we start every meeting with my why. What is my why? Why do I do this? We do it every meeting. And I love it because it's fun to listen to people. And so I would say my why changes and has changed throughout my career. At this point, I'm towards the end of my career. And I've been doing this for a long time. And I feel like I've made a lot of mistakes, and I've actually learned a thing or two, and I feel like I'm on the clock, that my time is limited. And I also find myself in this very unique situation where I am part of an integrated delivery system. And if I can't do it here, I can't do it anywhere. And so I feel like I know what I'm doing. I feel like I have limited time, and I'm in a unique situation where I have a willing clinical partner who's willing to figure this out with me. And that's exciting to me. And then the One Utah Health Collaborative, it is a unique thing, and I want to say thank you because you've given us a forum where we can sit at the same table. And what's interesting about that is we're all dealing with the same problems. And that was very refreshing for me to know, and it also helped me feel like, I'm not alone in this. And I have people that are struggling with the same things, whether they're my competitor or not. And that was very comforting to me in an interesting way. So.
Evan, what keeps you going? And then if anyone's got a question, we'll go to that.
Yeah, no, great question, John. I mean, when I tell our leaders all the time, as executive leaders or administrative leaders, the two most important audiences are obviously your colleagues and your physicians. And we've got just wildly impressive subject matter experts in both of those two audiences. And if we can create an environment for them to flourish and they can achieve goals that they never thought or imagined that they could through leadership, I think that's what sort of keeps us going. It's the ultimate people business, healthcare is, and so the interactions that you have with those groups of colleagues and groups of physicians are what sort of inspires me for each and every day.
Thank you. Well, thank you all for having that. Is there a question? I think we got time for maybe one, maybe two. Great. Dr. Valentine. Just yell. We're not ready for that.
Yeah, Chris Valentine, Medical Director for Optum Care of Utah. Appreciate the kind words for Rob recognizing the depth of our leader. I do want to kind of try to connect a couple of points that were made around medical gaslighting, which is coming under increasing scrutiny, but also connecting it to value-based care and understanding, is there a relationship there? And as you said, we kind of unintentionally designed a system that is built on volume. My background is family medicine. Oh, thank you. My background's in family medicine. I actually I was in private practice in West Valley, saw a lot of those social determinants of health barriers in that community over 20 years ago. But my question is just kind of connecting these, some of these concepts together and understanding what are the ways in which advancing value-based care and moving away from a volume-based system that really is rewarding providers for just getting in one more provider, less time with the patient. And looking at value-based care not only is something that's sustainable, but something that in fact can improve patient experience.
I have very specific. So I think there are three components to value-based care. And first of all, thank Optum, great partner. So thank you very much. I don't think there's a health plan in the country that doesn't use Optum. There's three components. One is the financial mechanism. So aligning those incentives. And candidly, that's the easiest thing to do. Like I can go sign a contract with anybody and easy. Second component is, okay, once I sign that contract, the operation, how do you operationalize that is very, very difficult. Because you have to change culture and you have to change mindset and you have to change incentives and how you work. And that's very hard. And then the third component is data and analytics. Because if I sign a contract and let's just say, okay, then we change our operations, if I'm not giving you data so that you can make actionable decisions, then it all falls apart pretty quick. So those are the three components in my mind about value-based care.
Great. Is there another comment we can get a find? All right, we are at a time. I want to just do a rapid question, and we can start with Evan, then go Gina and Rob, and it's the magic wand question. If you had a magic wand, actually my son's going to Harry Potter World tomorrow, so he's been talking all week about the wand he's going to get. So if you had Dumbledore's wand, the big wand, what would one thing you would change about Utah's healthcare system overnight, and what would it be? What would it be, and why?
Well, I don't know if it's Utah specifically, but more on a federal basis. It's a little bit concerning right now. If you look at most of the publicly traded stocks, they've been a little bit depressed with the red wave experience that we've seen, and some of the cost-cutting efforts and what that can do to all of our funding mechanisms. So, my magic wand would be to slow down some of that, or to have a methodical, data-based approach at some of these efforts versus what we're seeing sort of play out right now with this administration.
Great, thank you. I hope you get that wand, Gina.
There's a lot. I agree with that. I think seamless, easy care, right? How we can make anyone who maybe has no healthcare background, doesn't understand anything about healthcare, really understand their next steps and process would be a huge magic wand for me.
I'm becoming obsessed with two things. One is just the PCP shortage in Utah. I think we're sitting at the table, we're number 49 in the country, number 50. In other words, we're the worst state in the country when it comes to access to medical care, PCPs. And we got to figure that out. And then the second thing that I'm becoming obsessed with over the last 4 or 5 months is rural health care. I just think it's a huge crisis and a hard one to figure out.
Thank you. This has been a great conversation for me, and honestly gives me a lot of hope and a lot of pride in Utah. We have excellent leadership that cares about doing the right things and making things better. And I know all of you and run into next level downs and operations. We're all trying to make an influence in our own realm. So thank you to everyone here who's trying to make a difference, and thank you to our 3 leaders who joined us today. So thank you.